Okay, inflammatory bowel disease is often associated with arthritis. Don't forget there are many extraintestinal manifestations of these conditions to include arthritis, but other things like chronic active hepatitis or iritis or rashes. So you want to remember that both ulcerative colitis and Crohn's are associated with an arthritis. Here's the points I do want to make. It's interesting that in ulcerative colitis, when the colitis is active, the peripheral arthritis is often active. Crohn's doesn't really obey that rule as well. Both conditions, Crohn's and ulcerative colitis, are associated with an ankylosing spondylitis-like manifestation and a peripheral arthritis. It is the peripheral arthritis in ulcerative colitis that follows that rule of active gut, active joints, treat gut, joints get better. Crohn's, the peripheral arthritis, doesn't follow the rule as well. But the ankylosing spondylitis kind, the sacroiliitis, neither particularly in ulcerative colitis and in Crohn's is the gut related to the back. The back sort of runs its own indolent course. It doesn't really care how active the gut is. And perhaps they might ask you that on the boards. And basically in that slide I state that Whipple's disease probably doesn't belong in the seronegative group, but again, Whipple's is an infectious arthritis associated with malabsorption, arthritis, clubbing, fever, lymphadenopathy, and of course CNS disease, which looks a lot like CNS vasculitis, looks a lot like CNS sarcoid. The infection is T. Whippley, and it's treated with antibiotics. Okay. Distribution. When you look at a question, one of the first things I want you to do again is remind yourself, which joints am I being told? And the hand is such a wonderful area to identify where your differential diagnosis should be really given a lot of credence to. If there's involvement of the DIPs, we've hammered how, besides osteoarthritis, psoriatic and gout can do that. MCPs are rarely, if ever, affected by plain old simple osteoarthritis. And here I enumerate all the causes of PIP synovitis and of MCP synovitis. That's just a sort of a thing as you look at a question. All right. Let's start moving to exotica a little bit, but exotica that tend to find their way onto board kinds of questions. And these are a group of diseases that don't always fit a simple classification, though there are some who argue that Behçet's belongs in the vasculitis group. But just to keep things entertaining, I'm going to just do these somewhat randomly, follow it in the same order that we have it in the booklet that you guys have all pre-read at least twice, right? Okay. Behçet's disease, a recurrent oral buccal, and genital ulceration. There is a differential diagnosis to include HSV type, to include herpes type 2. But what's typical of Behçet's is the iritis or uveitis and posterior uveitis, also retinal vasculitis. Other things that these patients get are cutaneous involvement. We'll talk about that. They get synovitis. And they get meningoencephalitis with CNS involvement. So, aphthous stomatitis, genital ulcers, iritis, arthritis, cutaneous vasculitis, and meningoencephalitis, they quite often in the board kind of question will describe the pathergy phenomenon, where a patient who has blood taken develops a localized reaction at that site. That thing can sometimes be invoked or induced by just taking a needle and sticking it under the skin, and you get a wheal or flare or an urticarial-like reaction, and that's fairly typical. So if you see that on your board question, you move right along to Behçet's and you don't read a thing more. The oral ulcer of Behçet's, I can't look at it and tell you that that's Behçet's. That can just be regular oral aphthous stomatitis, and there's some patients who just get this idiopathic aphthous stomatitis who don't have Behçet's. But once it's oral and genital and recurrent, then you've got to consider that as part of your differential diagnosis. Again, these scrotal ulcers, I don't know that they're part of Behçet's, but if they're starting to add up and you start getting a patient who has this very bad form of iritis, known as hypopion. Hypopion is just pus in the anterior chamber that you can visually see. Can everybody see that clearly? Excellent, I'm delighted. And that just means that you've got such a massive number of white cells, they've just sunk to the bottom and you can see them. But any other bad iritis can give you Behçet's, can give you hypopion. Behçet's is just the one that most of us associate with hypopion. So the pathergy phenomenon, to remind you, hypopion, which is pus in the anterior chamber, a large vessel vasculitis, and be careful of a patient who has hemoptysis. Patients with Behçet's get pulmonary aneurysms, and that's what they can die from. So that's a cause of mortality. They get an acne-like papulopustular lesion on their skin, obviously, pulmonary aneurysms. In Europe, it looks like things are a little different, and they get more CNS involvement than they do in our country. Enodosum is described, and there are many, many causes of enodosum. We'll come to that. Arthritis, and then they sometimes get subcutaneous or superficial thrombophlebitis. The treatment is symptomatic. Corticosteroids for bad internal organ involvement. You add drugs like Imuran or cyclosporin or cyclophosphamide or methotrexate for bad internal organ life-threatening disease. But for the rashes and for the bad oral ulcers, you do need to know that thalidomide or colchicine or dapsone are useful drugs. And thalidomide, the major side effect, of course, is a peripheral neuropathy. You know that. But the thing that we're so hysterical about is the pregnancy. And so patients have to have at least 2 forms of contraception concurrently in a program called the STEPS program before that drug can be prescribed. Juvenile idiopathic arthritis. It is somewhat unlikely and unreasonable that they're going to give you a kid in a question. But you might get an adolescent/teenager and sort of it blurs into adult medicine, and you're all going to see patients like that. So it's not unreasonable that you have to have some basic knowledge of juvenile idiopathic arthritis, which is essentially a form of arthritis in kids less than the age of 16. There's 3 subtypes. The classic Still's disease, where they have a rash, fever, weight loss, night sweats. And the rash is classically described as a salmon, as in fish, salmon-colored, maculopapular rash on the trunk. And in that kind of patient, you see, weight loss, lymphadenopathy, spleen. The joints may not be that prominent, high white count, high sed rate. On the other hand, there's 2 subtypes in which you get joint involvement. The first subtype, which we call the oligo or pauci-articular group, and that is subdivided into 2 further subtypes. Young girls, obviously, who are ANA positive with asymptomatic iritis. And then the boys who are a little different. Then there's the polyarticular group. Most of these patients are rheumatoid factor negative. However, there are some patients who develop rheumatoid arthritis before the age of 16, and this is the patient who has a polyarticular presentation with rheumatoid factor positivity, and that's why the Europeans for 20 years have argued that we shouldn't use the word juvenile rheumatoid arthritis, and at long last in our country we've caught on and we've dropped that now, and we've all signed on to the juvenile idiopathic arthritis. However, what they do love on the boards is the adult Still's question. The adult who has a rash and a fever and joint pain is adult Still's. They have arthralgias and myalgias. The arthritis might not be that prominent. The rash is on the trunk and proximal extremities. May be worse at night. They may exhibit Koebner's phenomenon. They may have lymphadenopathy, splenomegaly, serositis. It is sometimes self-limited but can be quite violent. There's the picture. All right? Salmon-colored truncal rash. Osteoarthritis. Such a common condition, not too many board type of questions. So let's think, how can they ask us board questions? It's the most common joint disorder, of course. The risk factors being heredity, obesity, hypermobility, and smoking. There's local biomechanical factors, none of which you want to know about for this kind of reason. other than, you're not going to be asked that. Radiographic features are quite specific, and we'll try to show you them. But there's some things you are expected to know. Osteoarthritis doesn't occur in a 15-year-old. It's in a slightly older person. There's not much early morning stiffness. Early morning stiffness or gelling is more part of a rheumatoid or an inflammatory condition. There's sometimes crepitus of the joints. There usually isn't much inflammation. There can be. It's argued maybe 10% of osteoarthritis is quite inflammatory, maybe a higher percentage. So don't be put off an erosive inflammatory arthritis, which might be osteoarthritis. There's bony enlargement and tenderness. The SED rate tends to be low. Don't forget, if I'm 75, my SED rate is entitled to be 50. 2/3 age is an acceptable SED rate. Do not fall for that one. So a SED rate of 44 in a 78-year-old is normal most of the time. The synovial fluid, as we've pointed out, tends to be a transudate, not an exudate. And the radiological features are osteophytes, joint space narrowing, malalignment, all the things that you know. So in this particular thing right here, we've got a patient with a DIP. The third DIP looks red and angry. Differential diagnosis is osteoarthritis of an inflammatory form. Gout, oh, beautiful. Psoriasis. How about this for a question? They love this kind of question. They tell you all about this patient with osteoarthritis, you're smiling, and somehow snuck into the question is a little thiazide diuretic that she's innocently taking, right? And her diagnosis is gout superimposed on osteoarthritis. You're not going to get that question wrong, right? This is the smartest group we've ever had. No question. These patients get Heberden's nodes, which is essentially bony hypertrophy of their DIP, and a Bouchard's node, which is bony hypertrophy of the PIP. So if they describe Heberden's and Bouchard's, you just smile and you're saying osteoarthritis. And they get what's called a seagull wing distribution, where the middle of this area here is eroded, and I'm not sure if that's coming through, whereas in psoriatic arthritis, you tend to get erosions. What I told you was the mouse ear appearance. So I can take a look at this x-ray and say, okay, that's classic osteoarthritis. So everybody looks at this x-ray and they say, what's happening here? Osteoarthritis of the left hip. There is no hip joint. It's destroyed. It's narrowed. And that's a patient who's going to have groin pain and not ambulate very comfortably. Osteoarthritis of the hip. Osteoarthritis picks in all joints, but it loves large joints. So besides the nodal osteoarthritis that I showed you in the hands, you can have large joint, hip or knee. Hip and knee, large joint, is obviously related to weight, and you cannot be 496 pounds and 4'8" and be surprised that you develop hip or knee osteoarthritis, as I saw a very sweet but quite tragic young woman about 6 months ago. I'll never forget her. And she had very bad osteoarthritis, and it was really tough for me to tell her, you just have to do something about this problem. But if you look at this x-ray, what we can see is that there's joint space narrowing more in which compartment, medial or lateral? Because that's where your fibula is, right? Cool. So that's the lateral compartment. And you see that in osteoarthritis. So that's a tip-off right there. So what's the treatment of osteoarthritis? They will ask you this. Simple, plain acetaminophen or Tylenol. Most patients don't want to stay there and they move on to non-steroidals. And because they're elderly, there's a propensity to prescribe the COX-2s more than the non-specific selective COX drugs. There's no evidence that the COX-2s work better. There's a new group of drugs called the hyaluronic acid derivatives, the Synviscs and the Hyalgans. There's a role for those drugs in patients who don't want to have an arthroscopy, have failed corticosteroid injections into their knee joints or hip joints. And by the way, the question that I'm most often asked is, how often can you inject somebody with a corticosteroid into a large joint? The answer is quite frequently. There are studies coming out these days to show that you can. So I would be surprised if you asked that in a board question, but the answer would be if they say, look, patient doesn't want surgery, she's had 2 injections, she's requesting another one, is it reasonable? I'd say, yeah, it is reasonable for steroids. But this other group, the Synvisc and Hyalgan, those drugs are supposed to improve the viscosity of joints. I think the evidence that they work is very slight and drug company driven. I'm underwhelmed. Other drugs that are used in the treatment of osteoarthritis include the tetracyclines, again for their impact on the tissue metalloproteinases. So And the Plaquenil group of drugs, antimalarials, have been used, and there's some data coming out that the bisphosphonates might be useful. We can get into why maybe afterwards. All right, where are we going? We're going to the connective tissue diseases. A nice topic, always on your boards. One of the first things to understand straight away is that the connective tissue diseases are not pure, like all of us. Nothing's simple, nothing's easy. And patients aren't always pure lupus. There's always a bit of something stuck into them. And on your boards, they're going to play with that. What isn't important is what the name of the disease is. It's the organ involvement that's going to drive your decision making. So as you look through this question that you've got, yes, you're trying to make the diagnosis, but if you can't quite get the diagnosis, focus more on what organ is affected, because that's going to drive your decision making process. It does so clinically, it does so on board questions. So the antibodies are asked all the time. ANAs are positive a dime or dozen in people. Only 5% of patients who have a positive ANA in a reputable lab actually have lupus. The other 95% have some other connective tissue disease process, have some other chronic infection that has nothing to do with a connective tissue disease, are elderly, have some fibrotic process or sarcoid, lots of causes of an ANA that's positive. We used to be much more excited about whether it's peripheral or speckled. We're not all that excited these days. One pattern you do need to remember is the centromere pattern, which you'll see in CREST. So, anti-double-strand DNA found in 50% of all lupus. Therefore, 50% of patients with lupus can have lupus without a double strand. However, 99, close to 100% of patients who are double-strand DNA positive have lupus. It is a very specific test. So if you see double-strand DNA, and they may even describe the technique by which it's done. There's a FAR assay, which is more sensitive and less specific than a Crithidia lucilia technique. If they go that far, they may go that far. But whichever technique, if you see a patient with a double-strand DNA, you know they've got at least lupus or a component of lupus as part of their overlap syndrome. Anti-SM, not smooth muscle, but Smith, found in 25% of lupus. So 1/4 of lupus patients are going to have it. Again, it's a quite specific and suggestive test for lupus. You're expected to know that. Anti-SSA, or Rho in the old days, found in lupus, particularly a form of lupus called subacute cutaneous lupus. Also found in Sjogren's, both primary and secondary. You are expected to know that anti-SSA is relevant to a young woman who wants to have a baby. Perhaps 1% of women who are SSA positive have congenital heart block or fetal lupus, neonatal lupus. And the way you screen for neonatal lupus is by doing the SSA first. And you warn your patient you have a 1 to 2% risk of developing neonatal lupus, which is the baby with lupus. It's self-limiting in that after 6 months, all the symptoms and signs are resolved, except the potentially dangerous, irreversible heart block. And the way that is monitored for is between weeks 16 and 22. You're looking for fetal bradycardia. And if found, you may want to give the mother prednisone. Of course, you need a neonatal cardiologist on board who may even have to pace the baby in utero. So I'm just reminding you of why you might be asked about SSA. Okay, you all got that in your heads. SSB, less common, found in patients with lupus, more commonly found in patients with Sjogren's. RNP, specifically the anti-U1-RNP, is found in very high titers in a very specific form of an overlap syndrome called mixed connective tissue disease. Stated another way, that mixed connective tissue disease is one of the many kinds of overlap syndrome. This particular overlap syndrome that Sharp described in the 60s has anti-U1-RNP in very high titers and is an overlap of lupus, of scleroderma, and of polymyositis that tends to have a more benign prognosis that tends not to have CNS nor renal disease. Okay. There are many other overlap syndromes. Overlap rheumatoid lupus, you can call it lupus. Overlap dermatomyositis, lupus, you just describe what the components of your overlap are. But mixed connective tissue disease is a very specific kind of an overlap syndrome. Are we clear? With a very high anti-U1-RNP, with no CNS nor renal involvement, most people would argue. This is all a question of semantics, but on board questions, they sometimes play on those semantics. I don't know why. Antihistone antibodies are found in drug-induced lupus. Don't forget that. You see the antihistone, you smile, and you move on to your next question. Anticentromere are seen in CREST. CREST stands for calcinosis, Raynaud's, esophageal stuff, dysphagia, sclerodactyly, and telangiectasia. CREST is a fairly benign form of scleroderma that tends to not have internal organ involvement, but occasionally can wind up with pulmonary hypertension. Okay, and we'll come back and pray on CREST a little bit later. Anti-SCL70 seen in scleroderma patients, and a relatively low percentage of patients with scleroderma, between 5 and 10%, perhaps 8% is a more accurate figure. But anti-SCL70 is very suggestive. You find that, that's very suggestive of progressive systemic sclerosis. Okay, let's talk about the connective tissue diseases, and let's jump onto lupus. The one that you're definitely going to know a lot about and hear a lot about and be asked about. The criteria, so I've enumerated them for you here. Most people argue that these criteria are very loaded towards mucocutaneous stuff, and therefore you can have skin lupus and that you're going to qualify for systemic lupus. Just remember that there's photosensitivity. By the way, drugs are much more common causes of photosensitivity than lupus. The tetracyclines and many other drugs can do it. And there's a condition called polymorphous light eruption, which is the most common cause of photosensitivity, which has nothing to do with lupus. Blood stuff, thrombocytopenia, anemia, leukopenia, renal disease. We'll talk about all of these in more detail. Anti-double-strand DNA or Smith, arthritis or arthralgias, but for the criteria, it's arthritis. A malar rash. There are other causes of a malar rash to include rosacea, sarcoid of the face. We'll talk about that later on. Those are the more important ones. And it's lupus pernio is sarcoid of the face in a malar distribution. CNS lupus. And when we talk about CNS lupus, we use the word cerebritis, not CNS vasculitis. It is quite rare that in a patient with lupus who has CNS involvement that you find vasculitis. That is very rare. Oral lesions, which are oral apathy and serositis, pleural effusions. Okay, now lupus, cutaneous lupus takes a variety of presentations. Here's an individual who has discoid lupus, which you can tell by the scarring, the hypo and hyperpigmentation. Discoid lupus seldom goes on to be systemic. Only 5% of discoid lupus patients have systemic features. So you could argue it's a benign disease. Tell this patient. How scarring is this? And discoid rash loves certain areas. The temporal area causing alopecia in this type of distribution, it loves the ears, in front of, inside of, and behind. It's classic discoid sites. But it doesn't only affect the face, it may affect the trunk. Here's a patient with a classic butterfly rash. Sometimes they'll drop you a hint when they say that there's nasolabial sparing. This fold here is spared, whereas other rashes may not give you nasolabial sparing. As you can see, this is a male, and in general, males do poorly with lupus. Not a good thing to be a male with lupus. Here's a patient again with a systemic rash. It looks like your classic malar rash, but I don't know that this is lupus. This could be lupus pernio. It could be some other cause of a rash like that. Patients with lupus get alopecia of two kinds, the patchy kind or this diffuse kind that you see here, which may respond to a variety of treatments all the way to having corticosteroid injected into the scalp. Patients with lupus get oral apathy. I cannot tell you that when I look at someone and I see their apathy, that's a lupus oral apathis. It could be anything that's causing this. On biopsy, though, that this lesion often has a vasculitic look to it. Patients with lupus can have cutaneous lesions, Janeways and Osler-type presentations. But here's something I want you to remember. Patients with lupus get arthritis. It is never erosive. And we use this word Jacquet's arthritis, which shows you this patient who has all kinds of funny-looking deformities with ulnar drift. But you can tell this patient differently from a rheumatoid, because in a rheumatoid, when you take them and you straighten them out and you let them go, they go straight back into ulnar drift. If you can take, in this condition called Jacquet's arthritis, which is a patient with lupus, you can take these deformities and reverse them, and they won't straight away drift off. That's why we use the word Jacquet's, a reversible sort of situation where their subluxation and everything else can be put into a sort of straightened out position by you physically, but a rheumatoid you can't. But the point to remember, there are no erosive changes in a lupus arthritis, no erosions. So I can see a picture of a patient like this. It looks vasculitic to me, or a little area of infarction. I don't know that this patient's got lupus. This could be a patient with infective entoid factions, nephritis, in which a patient with epilepsy is going to die. I think it's very reasonable to expect for you to be known or to know that you should use high doses of steroids, perhaps IV and or Cytoxan, as a life-threatening type situation. Again, here I enumerate all the different presentations that CNS lupus can give you. In an MRI, you might see some areas of demyelination, which may be difficult to delineate from MS, but most decent neuroradiologists will help you with that. The one thing you will always be expected to know is that lupus affects the kidney, and most of the time it can be pretty innocent and you don't know about it unless you biopsy the patient for reasons that I wouldn't understand. You wouldn't know about it. They don't necessarily have proteinuria or red cell cast, but don't you dare look at a question on lupus without paying a lot of attention to the urine. And if there's significant proteinuria or nephrosis, then you're going to think that they have membranous nephropathy, or what's known as a type 5 lesion, WHO type 5. If you have proteinuria, which is not too much, but you have hematuria and specifically red cell casts, then you've got to consider that they have a proliferative nephritis, and that you may want to biopsy that patient, and you may want to give them prednisone or Cytoxan. The patient with membranous nephropathy does not respond as well as the patient with a proliferative nephritis with red cell casts does to prednisone and or Cytoxan. So just some of the renal involvements. The renal involvements may be focal or diffuse, and a decent pathologist will be able to tell you whether there's a lot of activity and that the disease process is ongoing and needs to be treated with steroids or Cytoxan. Another presentation, by the way, of lupus could be something like RPGN, and you would know RPGN, or rapidly progressive glomerulonephritis, by a rapid increase in creatinine. And that kind of patient, you would give IV Solu-Medrol and or Cytoxan. That you would hit the panic button. Other involvement by lupus, other than joints and skin and renal and brain, is cardiac, most often pericarditis, pericardial effusion, but you can get what are called Liebman-Sachs endocarditis, which is a verrucous endocarditis, sometimes associated with antiphospholipid antibodies. You can get eye involvement. Eye involvement might be through drugs with hydroxychloroquine, which is a favorite drug for skin and joint involvement. If you've got a question in which they talk about skin and joint and they're asking you which drug you would use and there's nothing else bad, Plaquenil or hydroxychloroquine would be your drug of choice for skin and joint. And this is so-called Plaquenil retinal toxicity, quite rare. But lupus more commonly affects the eyes by giving you exudates, retinal exudates, and transudates. By the way, another way that it can affect the eyes through renal involvement, giving you malignant hypertension, giving you exudates and transudates, little microinfarctions. So, what do I expect you to know for a lupus question in terms of treatment? If it's skin and joints, you fall in love with the antimalarials. On the other hand, if there's serious, life-threatening internal organ involvement, horrific thrombocytopenia, horrific hemolytic anemia, very bad CNS disease, or clearly where you have to use steroids, then steroids are reasonable. But what you see most of the time is they want to trap you in the boards to saying that you would prescribe steroids for relatively frivolous involvement. Be careful of that. If you find yourself trapped now with steroids, they may then ask you, well, what drugs can you use as steroid-sparing drugs? And you would use Imuran, cyclophosphamide. Those are excellent steroid-sparing drugs, depending on the indication. By the way, every patient that you start on prednisone at a dose of greater than 5 milligrams per day for longer than 3 months gets a bisphosphonate. They love that on the boards. We'll come to that later on. Another drug that is gaining ascendancy is mycophenolate mofetil or Cellcept in the use of lupus. There was a great study that came out of the Hong Kong group showing that this drug is really pretty good and perhaps as good as Cytoxan in renal lupus. Every once in a while you have to use plasmapheresis in a lupus patient where the patient looks like they're trying to croak on you, where they're trying to die. Otherwise, pheresis doesn't have a lot of evidence for use in lupus and a lot of other conditions. Board questions love drug-induced lupus. In drug-induced lupus, you get serositis, joint pain, a rash, but no CNS and no renal involvement. Are you clear? But you do get antihistone antibodies. And I enumerate some of the drugs. I would emphasize the ones that are most common: hydralazine, alpha-methyl dopa, reserpine, INH, antithyroid drugs. But the one that's most common is procainamide. That's the one they love on the boards. Again, absence of CNS and renal, fever, serositis, rash, the nice history of the drug. And I told you that the anti-TNFs can give you a lupus-like syndrome. So perhaps you've got somebody sneaky who wants to catch you out. None of you guys are going to fall for that one. What about lupus in pregnancy? I don't think they'll ask you that, but just to point out that sterility and fertility are very comparable to control patients. That if you've got a patient who's had very active, severe lupus, you may want to discourage them from having a child. But is there a very strong correlation between pregnancy and lupus and increase in activity? It's argued that if there is an increased activity of lupus during pregnancy, it's more of mild stuff like joint pain and arthralgia, not very sinister stuff. But there's a lot of debate about that in the literature, so therefore I don't think you'll get a question like that. You will be asked something on the overlap syndromes. And I've already addressed that an overlap is simply where you have a patient who is of an admixture of two different diseases or three or four. And so the admixture that we call MCTD is the one with the high URNP and the overlap of lupus, scleroderma, and polymyositis. But a lot of patients don't fulfill clearly those two or three, in which case we would call them an undifferentiated connective tissue disease where you don't exactly know where they are. Or if they clearly are an overlap of rheumatoid or polymyositis, you will describe Mrs. Smith as having an overlap of rheumatoid and polymyositis. The thing about these diseases, though, I see them 6 months ago and they look rheumatoid and polymyositis, and today they come in and they look scleroderma and something, and I look at my notes and think, whoa, what was I smoking on that particular day? And so they may prey on that in your board kind of question where these patients move from one into another, and so that's not unusual. What I'm saying is they're not stable. So how do you want to sort out in your board question where these belong? So the MCTD one is the high U1-RNP, and then I've already told you some of the features, but the ones that you want to clinically put in your heads are, for the MCTD patients, beside the U1-RNP, is the arthritis, the very significant Raynaud's, the esophageal problems, and they have very swollen, sausage-like hands. That's a dead giveaway. If they're describing this patient with very swollen digits, sausage-like, you just smile and say, no problem. One problem I am having is my voice. Can you still hear me? Excellent. Okay, rashes, splenomegaly, neurological stuff and renal stuff. In this particular study, they enumerated it as 10%, but most people who are purists will say if there's CNS or renal disease, then you cannot call this an MCTD patient. You need to call them something else. It's so stupid, the whole thing. What do patients die from MCTD? They develop pulmonary hypertension, myocarditis, sometimes mesenteric vasculitis, pulmonary hemorrhage, amyloid. So the clinical features, again, are edema of hands, arthritis, myositis, a positive ANA, a high U1-RNP, and then an interstitial pneumonitis. Everybody see those hands looking slightly thickened and sausage-like with big-time Raynaud's? You just mark that question, MCTD. You treat the organ that's affected. Obviously, if there's bad pleurisy, you might just try a non-steroidal. But if there's a big pleural effusion and ascites or something else, you might have to put them on prednisone. But you particularly would use prednisone for the pneumonitis, sometimes with Imuran. Unfortunately, these patients are not quite as benign, and when Sharp described his group in the 1960s, he sort of argued that the prognosis was good, and he was correct. In the beginning, the prognosis is good, but with time, these patients do develop pulmonary hypertension, and that's what gets them. I mentioned this condition called UCTD, or undifferentiated connective tissue disease. So when I don't quite know where this patient is or fits, a bit of Raynaud's, a bit of ANA, a bit of joint pain, I'd say she has an undifferentiated connective tissue disease process. And if you follow these patients long enough, the majority of them wind up to be more scleroderma-like. But some of them disappear completely, and we wonder if we really got the diagnosis right. And I've had patients over the years who, wow, they've just disappeared their disease, and that's kind of a neat outcome. But most of the time, they unfold into one of the specific kinds of connective tissue disease process. All right, antiphospholipid antibody. You will be asked this. There's a patient who has recurrent vascular thrombosis, arterial and venous, and or pregnancy losses, and there's all kinds of names for pregnancy losses out there, with persistent elevated antibodies. Of course, we could give a whole lecture all on antiphospholipid antibodies on their own, but I just want to highlight some of the points. They have venous arterial thrombosis, recurrent fetal loss, a mild thrombocytopenia, and there's association with the rash of livedo reticularis. So the antiphospholipid antibody tests, you want to remember that there's the one for the lupus anticoagulant, sometimes with a prolonged PT or PT that's not corrected by adding normal plasma. And I don't think on a board question you're going to be asked exactly how to do the test, though if you were taking a rheumatology boards, you would be expected to. That you would know that there's anticardiolipin antibody which can be picked up by an ELISA, and it can be IgG and IgM, and we argue whether IgG or M is more important, and we're still not sure. And some of these patients actually have false biological testing for syphilis, just to remind yourself that you don't fall for that. So anticardiolipin antibody is IgG or M done by an ELISA. I tell you there how you do the lupus anticoagulant test, and I give you some idea of how it's done. There are different labs all over the world that use different techniques, which is why we can never come together and agree what this condition really is and how you really should monitor for it, and worst of all, how you should really treat it. Though, if you have a patient who simply has the antibodies that are coincidentally picked up and they've not had any event, you probably don't need to treat them. Though some would argue that you may want to give them a low-dose aspirin. And I think if somebody checked me out and happened to find out, ran a bunch of blood tests on me and found out that I had these antibodies, I might stick myself on aspirin. But if I've had an event like superficial thrombophlebitis or a DVT, obviously you treat that DVT for 6 months, perhaps 2 years. There's some debate about that. But I would then leave myself on lifelong aspirin. On the other hand, if I've had, say, a stroke, I would probably put myself on Coumadin for 2 years. There's some evidence that now that you don't need to treat beyond 2 years. I cannot imagine a board question playing on that controversy. I really don't, so don't worry too much about it. Oh, I did want to point out this interesting condition which may be on your boards called the catastrophic antiphospholipid antibody syndrome, where these patients seem to coagulate everywhere, clot everything, multiple organ thrombosis, renal, and they look like Waterhouse-Friderichsen syndrome, they look like they have infarction of their adrenal. The those kinds of things. So if you see a diffuse thrombotic microangiopathic picture, particularly with a renal biopsy that suggests that, then you want to consider this condition of the catastrophic antiphospholipid antibody syndrome that my friend Ron Asherson keeps describing every year or so. He invents a new component of the disease. It looks a lot like TTP, and TTP can exist in lupus. The management, so if you have thrombosis with only one event, perhaps you treat them for 2 years, and these days we're arguing that you shouldn't do their INRs to 3.5. You should keep it closer to 2.5. Again, I think it would be very rough to expect you as a group to know whether it's 2.5 or 3.5 because there's so much debate. Recurrent pregnancy loss, and if someone is desperate to become pregnant, you are expected to know that you would give them heparin and low-dose aspirin, not Coumadin, please. But there's a lot of debate in this area, so I personally find any question that they ask in this area would be very unfair unless they gave it to you in very lucid terms. All right, changing gears. Sjogren's syndrome. Okay. If I have dryness of my eyes, that is called keratoconjunctivitis sicca, I would usually complain to you of grittiness or itching of my eyes. I won't walk in and say, my eyes are dry. So in their question, they might use the word grittiness. They might even say the patient is having some problems seeing. And obviously there's going to be visual acuity problems if you don't have enough tears. Don't forget that point. Dryness of eyes, of mouth, is called xerostomia. So if I have both dryness of my eyes and mouth, I can talk about the sicca complex. Sicca being Greek for dry. Sometimes you can have dryness of the nose and or vaginal secretions with dyspareunia, obviously. When do I start saying someone has gone from sicca into Sjogren's? We can argue like crazy. There are criteria that are coming out these days. But when a patient with bad sicca symptoms is ANA positive or rheumatoid factor positive or anti-SSA positive or has joint involvement or some of the other extra glandular manifestations, then we can start talking more about Sjogren's syndrome. Sjogren himself described 39 women, all with rheumatoid arthritis, who had dryness of their eyes and mouth and or recurrent parotidomegaly. That's primary Sjogren's. But we've extended the diagnosis now into secondary, where they have some other connective tissue disease process which isn't part of their Sjogren's, and that's what we call secondary Sjogren's. Clinically, primary and secondary behaves the same. So don't be trapped into some question. They act and look the same. Their antibodies are very similar. Their clinical outcomes are very similar. So it's just interesting to know, but it doesn't really affect the way you want to treat a patient. These patients have a non-erosive arthritis. Obviously, if their arthritis becomes particularly erosive, then what they've really done is that they started off with sicca complex and they've gone into rheumatoid, and they therefore have a rheumatoid with a secondary Sjogren's overlap, however you want to describe it. They have salivary gland involvement with parotids, but other salivary gland involvement is described. They have rashes to include non-thrombocytopenic purpura. They have renal tubular acidosis might be a presentation. So again, if you're taking boards and you don't know RTAs, you're crazy. And the nice way that an examiner can tie these two, examiners love to have questions that aren't pure rheumatology, but they sometimes love to overlap them. So just remind yourselves to go back and read RTAs tonight as well. They have peripheral neuropathies, bless you. Trigeminal neuralgias. CNS disease is rare in Sjogren's, but described. There was a group in the early 80s out of Hopkins that tended to over-describe this. Liver disease is described. Pulmonary disease, they have what's called LIP, lymphocytic interstitial pneumonitis, treated with prednisone and or Cytoxan. There is a very high incidence of lymphoma, non-Hodgkin's lymphomas, in patients with Sjogren's. You are definitely expected to know that. And it's the B kinds of lymphomas, non-Hodgkin lymphomas. Okay, so what are the diagnostic tests? You'd send them to an ophthalmologist for a Schirmer's test, and it's a piece of filter paper stuck in the eye. And if after 15 minutes there's less than 5 millimeters of wetting of that filter paper, the patient clearly has a positive Schirmer's test. But there's a lot of variations of that definition, but you are expected to know a Schirmer test. And there's a dye called a rose Bengal dye, which is a purplish, violaceous dye stuck in the eye that stains devitalized areas of the cornea. And again, ophthalmologists can help us with the diagnosis right there. Slit lamp exam is important. You can't really measure parotid salivary flow rates because they vary all the time. And so if I think of food, I get a Pavlov's response and I start secreting like crazy. So that's not a very accurate assessment. Sometimes you may be asked whether or not you want to do a minor salivary gland biopsy in a question. And ask yourself this: you would only do a minor salivary gland biopsy if it was going to change your management. Let's say, for example, they present you a patient who has dryness of the eyes and mouth, a positive ANA, and they also happen to have a wrist drop or a foot drop. We'll come to vasculitis in a second, but it's clear that they've got something motor neurologically going on. But you're not sure whether they have Sjogren's or not. Then I would do a minor salivary gland biopsy because that would change my management and I would put the patient on prednisone and Cytoxan. So don't frivolously go biopsying minor salivary gland biopsies because it leaves patients with a funny kind of sensation in their mouth, and there's an area that they don't feel or taste, and none of us want to have a part of our mouth that we don't feel or taste in unless there was a good reason for doing that biopsy. So there's your Schirmer's test to remind you that Sjogren's has extra glandular involvement, so arthritis, skin, pulmonary, GI, renal, which will be renal tubular acidosis, and CNS quite rare. I'm just reminding you of things that they love to ask on the boards. How do you treat Sjogren's? Obviously with difficulty. It's one of the toughest conditions to treat. As I stand up here with my mouth becoming drier all the time, it's clear that these patients suffer incredibly. Drugs don't work particularly well, and in your board question, you want to avoid drugs that dry them out. Get rid of their diuretics. Get rid of the amitriptylines or the tricyclic antidepressants. Any drug that you know that dries them out, you drop that. You're expected to know that group of drugs. But you can try the secretagogues, including pilocarpine, which works okay, and Cevalim. Both of these drugs are contraindicated in acute glaucomas. You wouldn't use them. Sometimes we use antimalarials, and for severe life-threatening organ involvement in a patient with Sjogren's, we may try prednisone and or Cytoxan. All right, let's change gears now. Scleroderma. You will be asked on scleroderma. So let's try and pick out what they like to ask on the boards. It's an uncommon disease. It occurs somewhere between the ages of 20 and 50. It's more sort of female to male. You may be asked a little bit about the vinyl chloride predisposing stuff. There was an outbreak in Europe in the 1980s with a rapeseed oil, the Spanish toxic oil syndrome. Certain drugs like pentazocine and bleomycin can give you a very scleroderma-like presentation. So how do we decide whether a patient has or doesn't have scleroderma? Well, thickening of the skin is the pretty obvious thing. Scleros and is thickening or fibrosis, and derma of skin. And so the criteria would be sclerodactyly. Please grab your own digits and just grab it just distal to the PIP. And if you can grab your skin easily, then you do not have sclerodactyly. But if you can't, then you may have sclerodactyly. Okay? And so sclerodactyly is thickening of the skin in and around the PIPs. And that is very suggestive of a diagnosis of scleroderma. Be careful of the diabetic and the diabetic pseudoscleroderma. And diabetics get that as part of a syndrome we'll describe later on. There are other causes of sclerodactyly other than scleroderma. But if a patient has digital pitting and bad Raynaud's, then you have to think about scleroderma. And I would argue that a patient doesn't have scleroderma unless they have bad Raynaud's in your question. There's some scleroderma lookalike syndromes, jackhammer disease, silicosis, toxic oil syndromes, the eosinophilic fasciitis, and scleromyxedema. I'll try and address some of those. Some other scleroderma lookalike syndromes. I mean, again, we're in internal medicine. You guys are going to be asked a bit about the porphyrias. Some of them can look a little like scleroderma. So can amyloid look a little like scleroderma. And some drugs. GVH, or graft versus host disease, has a very scleroderma look to it. So, As I said, patients with scleroderma have very bad Raynaud's. That's obvious Raynaud's. A vasospastic disorder, which is somewhat idiopathic, seen in about 2% of males in a random survey done out of Charleston, perhaps 4% of women. So Raynaud's is not a disease, it's an epiphenomenon. Some people become embarrassed and they flush or go white. In Raynaud's, there's an overreaction to the cold. That's all that it is. Very few people with Raynaud's go on to a connective tissue disease process. On the other hand, I disagree with this slide, and it's been argued in this slide that 90% of patients with scleroderma have Raynaud's. I say it's 100. I'm very unwilling to diagnose scleroderma unless there's big-time Raynaud's. And then there's percentages that I mentioned according to some other authors. So, Raynaud's has two varieties: primary Raynaud's, where there's nothing else going on, or secondary Raynaud's. And secondary Raynaud's doesn't just occur in connective tissue diseases. And be careful of a question that describes one-sided Raynaud's, particularly in an elderly woman. That would be more suggestive of a vaso-occlusive disorder like atheroma proximally. So think about that. But the connective tissue diseases, causes of secondary Raynaud's, repetitive occupational trauma, if you believe in thoracic outlet syndrome, drugs, beta blockers, the ergots, bleomycin, those can give you vasospasm, cryoglobulins, cryofibrogenemias, those kinds of things, big-time monoclonal gammopathies, that can give you a Raynaud's-like epiphenomenon. You know you're in trouble when you see hands like this. Okay, and this is a patient with waxy-looking skin. They have pulp atrophy. If you look at their fingers there, they've lost and infarcted major segments. And if you look at their palms, there's obvious telangiectasia. Okay, that's atherosclerosis. Now, looking closer at the fingers, that is soft tissue calcification that occurs at the site of an infarct. These patients get infarction in their digits not because of vasculitis. There's no itis in scleroderma. They have an occlusive vasculopathy. They infarct their digits and over time get soft tissue calcification. Here's another patient that you want to pick out. They may not show you a picture on the boards, but they may describe a woman who has an inability to frown. She doesn't really wrinkle that much, but around her mouth she has fissuring, yet her skin looks superficially young, and she may have some telangiectasia that we can't see. They may show you an x-ray like this, which shows you soft tissue calcification, and let me clearly point out a feature that I want you to remember. Can you see that this bone looks like it's being eaten away? Acroosteolysis. All that's really happening is that you've got an infarction of the bone and soft tissue area, and you're just getting eating away. So that's something that you may be expected to know on a board kind of question. But there's soft tissue calcification. Can you all see that? And can you see this digit over here where the whole bone has been eaten away? It might have been surgically removed or might just have, infarcted away on its own. Okay, scleroderma patients get pulmonary fibrosis. The lower two-thirds of the lungs. It is the leading cause of death, pulmonary hypertension. Pulmonary hypertension occurs for two reasons in patients with progressive systemic sclerosis. They get pulmonary fibrosis, which gives you pulmonary hypertension, gives you cor pulmonale. But you can also get a pulmonary arteropathy, in which the pulmonary arterioles become thickened and hypertrophied, and you get pulmonary hypertension where there is no pulmonary fibrosis. And we'll come back to that in a second. The other thing that patients with scleroderma get is dysphagia. And there's a patient with an enormous esophagus. And they got all kinds of peristaltic abnormalities, which can be defined in a number of different ways. But in a board kind of question, what you want to pick out straight away, am I dealing with limited scleroderma or is it diffuse? Limited, this is a patient who has had many years of Raynaud's. That skin thickening occurs late, and it's usually limited to the hands and face. That they get pulmonary fibrosis late and infrequently. That they sometimes get pulmonary hypertension, where pulmonary pressures are up, but there's no pulmonary fibrosis. And that's more the association with anticentromere in the CREST association. On the other hand, diffuse scleroderma is where there's this short duration of Raynaud's and the sudden bursting onto diffuse cutaneous involvement with skin thickening early. This is the group that gets pulmonary fibrosis more commonly. They get scleroderma renal crises. And the whole epidemiology of scleroderma renal crisis has been attenuated by which drugs? ACE inhibitors. You are absolutely expected to know that if a scleroderma patient has hypertension, you will treat them with an ACE inhibitor. And 20 years ago, if you came to round with me, we would see many more scleroderma renal crises than we do today because of the use of ACE inhibitors. And so you want to treat their blood pressure very closely. The antibodies that we've already spoken about are anti-SCL70, also known as anti-topoisomerase 1, and RNA polymerase 3, which is associated with less pulmonary fibrosis. So if you have polymerase 3, you have less pulmonary fibrosis. So what's the treatment of scleroderma? Number one, to recognize the disease. Number two, to understand that there's no drug that can cure this disease process. None. We used to try penicillamine in an era gone by, and we've come to understand that that drug really doesn't work very well. There was some theory that relaxin, the natural hormone that occurs in pregnancy, might make a difference. That drug has failed. So what we focus then is on symptomatic relief, treating the Raynaud's. And Raynaud's doesn't respond very well to calcium channel blockers, which, if you asked in the boards, is the drug of choice. Other drugs have been used, include prostacyclines for bad Raynaud's. There's been some intimation that Viagra might work well for Raynaud's. I'm actually going to Germany on Friday to present a paper in which we clearly show it does not. But people are trying it and writing about it. I don't think it'll be on your boards. By the way, Viagra does have other uses, and you want to know that it works in pulmonary hypertension, perhaps. But again, I don't think they'll ask you that on the boards. Drugs for pulmonary hypertension you are expected to know. And those are the prostacycline drugs like Flolan, injected IV, and the endothelin-1 receptor antagonist, also called bosentan. You may want to know that those drugs exist. They're tremendously expensive, but do seem to be useful. We don't yet have data that these phenomenally expensive drugs affect mortality. There's some small trials with minocycline. I think they're useless studies. I don't use the drug and wouldn't suggest a board question would ask you to do so. However, they may give you scleroderma with a twist. And the scleroderma with a twist is a patient who has what looks like scleroderma, except they don't get much involvement of the hands and face, and they tend to get lower extremity and perhaps arm thickening and woodiness of skin and muscle. And Raynaud's and visceral involvement are not particularly pronounced. And the way you diagnose this condition of eosinophilic fasciitis is with a full thickness wedge biopsy all the way to fascia. The treatment is with prednisone and or Imuran, and there is a relationship with hematologic abnormalities. There's another condition that burst into the literature about 15 years ago, and that's the eosinophilia myalgia syndrome. And you know, your examiners are sometimes senile and are still asking this question, so know about this. The L-tryptophan that patients were taking 15 years ago was found to be contaminated. And these patients presented with fever and myalgias and joint pain and arthralgias, and they had a rash with eosinophilia, subcutaneous edema. They looked a lot like early scleroderma and in fact behaved like scleroderma, except this was a particular contaminant in L-tryptophan, which is now being completely eradicated. So just a syndrome to know. All right, so muscle diseases you will be asked about. Polymyositis and dermatomyositis. And Bohan and Peter classified polymyositis in 1975 as idiopathic polymyositis, idiopathic dermatomyositis, that associated with cancer, a childhood kind, and then a form associated with connective tissue diseases. We don't use that classification much, and I'm going to tell you why. Now, you don't need to know classifications, but you do need to know the disease. And the first point I'm going to hit you with straight away, pain is not common in muscle inflammatory diseases. If you hear a lot of pain and the CKs are high, you want to think about rhabdo, and you all know the causes of rhabdo. But patients with polymyositis do not walk into your office, or there's not a board question which will go, this patient has proximal myopathy and cannot walk upstairs. They're going to drop you with synonyms for weakness and tiredness and no energy and don't feel like exercising. Those are the kinds of things that are going to sneak in. So it might just be fatigue or malaise. And that's when you sit up and you say, I remember what Sutesh told me. So these patients have every synonym that you can think of for symmetric proximal muscle weakness, but not much pain. They do get pain, some patients, but that's not so pronounced. But these patients have a muscle biopsy, which is particularly abnormal, EMGs, which are abnormal, and often have cutaneous abnormalities. So the classification system that I want you to sort of retain is this one: idiopathic polymyositis, idiopathic dermatomyositis, which is just polymyositis with a rash, dermatomyositis or polymyositis with malignancy, and it's more dermatomyositis. Then the childhood form stays. The association with connective tissue disease process stays. But here's the one that will appear on your boards. Number 6, inclusion body, or just inclusion polymyositis. And we'll come back to that little one. And there's several others. So let's just think about the differential diagnosis of a patient who's proximally weak. It does not have to be a myositis. And again, this is internal medicine. We always want to remember the way they could ask questions. Okay, it could be an endocrine cause, hypothyroidism. These are patients who are a little weak and their muscle enzymes can be slightly elevated. On the other hand, hyperthyroidism, these are patients who can be phenomenally weak, but their muscle enzymes are normal. By the way, in hyperthyroidism, you get cardiac involvement as well. Whereas in hypothyroidism, you don't usually get much cardiac muscle involvement, but you might get a pericardial effusion, correct? All of you are nodding, I can see that. Hyperparathyroidism can mimic a proximal myopathy. Hypocalcemia can, for whatever reason. Cushing's disease, perhaps one of the most common causes, particularly the iatrogenic type of Cushing's. Addison's disease, hyperaldosteronism, all of which are proximal muscle mimickers of weakness, endocrine causes. Drugs. Perhaps the most common cause, as I say, glucocorticoids of proximal muscle weakening, and it tends to be more legs than arms. Alcohol, and at this moment you're all saying, yes, please. Cocaine, not now. Colchicine, penicillamine. How about the statins? Yeah, they want you to know that the statins cause muscle pain. You'd be idiots not to know that. However, the statins don't usually cause tremendous weakness, though they can. So some unkind examiner may sneak in a statin-induced polymyositis-like picture. But most of the time, statins will bump your CK up 2 or 3 times, not much more than that, but obviously it can. But of course, you want to remind yourself, you see the statin, you see the muscle pain, you get rid of the statin, you get your answer right. Other drugs that I've enumerated there that might be associated with a proximal myopathy. The metabolic, the renal failure, the hepatic failures, the hypokalemia, the hypophosphatemia, the hypomagnesemia, all of those can make you weak. The infectious ones, the Coxsackie influenza, the mono, trichinella, not in our country, toxoplasma, rickettsia, all of those can, so rare. The miscellaneous, the psychosomatic, fibromyalgia, I don't know what the hell that is. Sarcoidosis, atheroma. We'll talk about fibromyalgia very quickly just now. The carcinomatous type of proximal weakness, the non-metastatic manifestation of malignancy, or the Eaton-Lambert reverse myasthenia syndrome. The storage diseases, which I don't think they're going to ask you on your boards. Again, it's more for the rheumatology board taker. Some patients that look like polymyositis, amyotrophic lateral sclerosis, myasthenia gravis, obviously with fatigability. Myasthenia tends to give you more eye involvement. Polymyositis usually doesn't give you eye involvement, but rarely can. But if there's eye involvement, I think, and you've got fatigability, please think of myasthenia. Thank you. The muscular dystrophies, all of them, I'm not teaching you those. The neurologist will. The neuropathies, porphyria, diabetics, Guillain-Barré, those are all self-explanatory. The facioscapulohumeral, limb girdle, myotonic dystrophies, all of those can give you proximal muscle weakness. Now, most of the time, patients who are profoundly weak with polymyositis have a CK that's 5 or 10 or 20,000, not a silly little 2 or 3 times normal. And let's talk about the 2 or 3 times normal. There are some patients or some families in whom a CK that is 2 or 3 times normal is normal. On the other hand, for those of us who exercise every day, I run every day of my life or lift some weights or something, not that you can tell, we get CKs that are minimally elevated from exercising. Mild trauma, a bump or a bruise, increases your CK. They might be sneaky and throw a board question in which a patient's had status epilepticus or been defibrillated or had some trauma that their CK is elevated. Remember that before you go do a muscle biopsy in that kind of patient as part of your board question. The enzymes might be normal in polymyositis at a stage where they've been treated or when their disease is clinically inactive. So that's the only way that you'll get a normal CK. If you want to do an EMG, and most of the times there's not a good indication because most of the time you're going to biopsy your patient, but some of the things that they might throw, if they give you an EMG as part of your question, you want to remember these. They may tell you that the waves are small amplitude, much like your EEG right now, that there's polyphasic motor action potential of short duration, insertional activity, spontaneous activity, sharp waves. These are all terms that your electromyographer is going to use to describe an inflammatory myositis. So just remember them for the boards and never remember them again. Okay, now, polymyositis, the patient is going to be weak with not much pain. But here's where you might get some clues by looking at them, and you're looking for a rash called heliotrope. Helios is Greek for purplish, violaceous rash in and around the eyelids with edema, and that's what this young lady has. I mean, she looks like she has too much makeup on. Gottron's papules. These are whitish, psoriatic-looking like plaques over the PIPs and MCPs. Gottron's. They will get you to dermatomyositis. Pretty easy, right? So Gottron's papules, heliotrope rash, sometimes calcinosis. There's some weird names that they may throw at you, mechanic's hands and V signs, and those are sort of specific kinds of rashes, which I'll describe in a second. One of the things to remember, though, is that if there's bad scalp involvement with a rash, that dermatomyositis loves to do that. So that's just a clue. Sometimes, if you look at the patient's cuticles, they're overgrown and they get what's called raggedy cuticles. All right, now, the muscle biopsy is usually self-explanatory, and you see all these round cells and atrophy and fibrosis, and, why would you ever do a muscle biopsy? And I would say most board questions are going to want you to do a biopsy because I don't know anybody who's willing to go on 60 milligrams of prednisone without a biopsy. And I would argue that for a question that you get, biopsy every patient. I do in the clinic. Muscle disease is obviously key, and it's usually pretty obvious, but remind yourself sometimes there's pretty serious cardiac involvement. And I had a patient the other day who was looking great, put her on 60 milligrams of prednisone. She went home and she went into full-blown pulmonary edema over the weekend, and there was no way for us to predict it clinically. And we felt very bad about ourselves, but you couldn't predict it. You don't do an echo on every patient with polymyositis. It's just too rare. It wouldn't be a high pickup rate. But they do get weakness of other muscles to include pulmonary muscles, and so you always want to ask them if they're short of breath. And some of the lung diseases they get are as a consequence of aspiration. Also with esophageal problems, they may get aspiration as well. What you do want to know for your boards, please, is the association with anti-Jo1 antibody and pulmonary fibrosis. You will be asked that quite frequently. All of you will get it right. Anti-Jo1 is also antihistidyl-tRNA transferase. But there are other synthetases that you may want to know, and Mo Reichland out of Oklahoma described patients who had myositis, interstitial disease, arthritis, and anti-Jo1, but there are many other of these synthetases that I don't think you will be asked on your boards. Joe 1 is the one you want to know. So what about the relationship with malignancy? I think it's pretty reasonable to ask you on your boards this type of question. There seems to be a relationship, particularly with dermato more than poly. And the kind of cancer that you get is the one that you would get pertinent to your age. So a woman of 55, ovarian cancer is more likely, but someone who's 45, lymphoma or something like that. But all the cancers are described. The thing to remember, though, the younger patient with polymyositis is more than likely the autoimmune kind. The older patient, you better suspect malignancy. And for your boards, the kind of malignancy and the workup that they're going to ask you to do is feel the thyroid, check the thyroid. Feel the breast, check the breast. X-ray the lungs, because that's another one you want to think about. Check the stool for occult blood. And gynecologically, you want to get them examined. That would be the quick workup that I would do in someone in whom I suspected malignancy. Okay? Treatment, obviously, get the diagnosis right. Every patient goes on 60 milligrams of prednisone. There's no study that's ever been done or will be done versus placebo. The problem with prednisone is you start with high doses, but most patients are over-treated. And it wouldn't be unreasonable for them to write a board question in which they say, patients had dermatomyositis or polymyositis for 2 years, and she's still on 15 milligrams of prednisone, and she's getting weaker, so the dose of prednisone was increased to 20, and she's getting weaker and weaker. What's going on there? Over-treated. That's a very reasonable question. I actually, 5 or 6 years ago, submitted a question like that. So think about that as a possibility. If a patient's on prednisone and you cannot wean them off, and you want to wean them off because you're worried about the usual side effects of corticosteroids, perhaps the best drug is methotrexate, but you have other drugs to include Imuran, cyclophosphamide, and more recently, the anti-TNF drugs. Does gamma globulin work? Yes, if you're in France. No, I'm kidding. In Europe, they tend to use much more of pheresis and globulins than we do. Remind yourself that globulins are expensive, have some side effects, require close monitoring, and the studies are kind of iffy, but perhaps you might be asked that. You will be asked, my favorite friend, inclusion body myositis. Quite a rare condition, really, but they love it on the boards. And this is the patient who is an elderly male who has an insidious onset of weakness, but they get both proximal and distal involvement. Their involvement tends to be asymmetric. Their legs are worse than their arms. Their muscle enzymes are not particularly elevated. An EMG shows more of a neuropathic than a myopathic pattern. And on biopsy, they have these inclusion bodies, these endomyosial vacuoles. There might be a little clue to the diagnosis. It's more common after the age of 55, and these patients do not respond to steroids. Please asterisk that stupid little slide that I've just given you. There's a question coming. Those are what endomyosial vacuoles look like, just to show you a pretty picture, but you'll never be asked that. Rhabdo, very often asked on your boards. Again, it's the crush, electrical shock, high temperature, status kind of predisposition. The toxins like alcohol, though I don't think it's a toxin right now. Now, barbiturates, heroin, cocaine, your lipid decreasing drugs, your statins, viral and bacterial infections, genetic electrolytes, collagen vascular, etc. Okay. Fibromyalgia. Asked on boards, and last year I think I spent too much talking about fibromyalgia. Let's get it quickly out of the way. A syndrome of chronic unexplained pain. 95% of patients are women. We don't know why, because women deal very well with pain vis-a-vis childbirth. But fibromyalgia is probably divided into 3 subtypes. 1/3 of patients who have a full-blown psychiatric disorder, in other words, manic depression or something pretty serious. 1/3 of patients who have an associated depression, and 1/3 of patients who seemingly don't have depression, nor a psychiatric problem. It's a very difficult syndrome to define, but for board purposes, most of the time they're going to tell you that they're tender points. But we well now know that not every patient with fibromyalgia has tender points. It is quite clearly for board questions a diagnosis of exclusion. Their SED rate is normal. Their CRP is normal. Their ANA is negative. There's nothing to find other than they ache for a long period of time and they're tender and they may not sleep well. Those are the kinds of symptoms. And they're females, usually closer to the age of 50. Sometimes they have co-travelers, they're depressed. Fatigue. Yeah, fatigue. Most people argue that chronic fatigue syndrome doesn't exist, that it's really just a component of what we label as fibromyalgia. But, I've started to write some editorials that we should drop the word fibromyalgia and rather use the word body ache. It's like a headache. It's a much better name. Chronic fatigue syndrome, all part of the same thing. Migraine, many of these patients have migraine and irritable bowel, and sometimes myofascial pain. Do you need 11 out of 18 tender points? Of course not, and I don't think any examiner on the boards is going to suggest you do. That's much more for studies. The things that they have: fatigue, sleep disturbances, paresthesias, mood disturbance, irritable bowel. Those are the kinds of things. Those are the tender points. Nobody expects you to know them. They're just tender all over the place. Be careful of the differential diagnosis. Rheumatoid arthritis, sometimes you get patients who have both. Fibromyalgia is phenomenally common, and it's argued that perhaps 1 out of every 12 women over the age of 50 have symptoms that you could call fibromyalgia. So be careful of a patient who has rheumatoid and fibromyalgia, but delineate out polymyalgia rheumatica, which we're coming to in a few seconds. Polymyalgia is aching of the shoulders and hips and nowhere else, with a very high SED rate and no tenderness in polymyalgia. And don't confuse polymyalgia with polymyositis. I don't know what it is about this group, the group taking boards. They somehow get very confused with those things. Patients with myositis usually aren't very tender, though can be, but have very elevated CKs. So I think it's very reasonable to check a CK in a patient with fibromyalgia and check their thyroid functions. As we well know, hypothyroidism is associated with fibromyalgia-like symptoms. So the characteristics: female, 46. They've had their symptoms for 7 or 8 years. As you can see, it's a sort of a litigious group that walks into your office who are quite disabled. It's obviously a very common problem and you have to deal with it seriously, but in terms of the boards, I'm just giving you some ideas of what it is or what it isn't. I think what you're going to be asked perhaps is, how do you delineate fibromyalgia, which is all over body ache, versus myofascial pain, which is a localized pain syndrome, and how on the boards they love to talk about a patient with chest tenderness, where they tender to the touch, but their EKG is normal and echo's normal, then they probably just have myofascial pain. And in myofascial pain, it's a localized area of fibromyalgia where you have what we call more trigger points than tender points. Tender points are more with fibromyalgia, and if you hit on this particular trigger point, they may jump. It's called the jump sign. And their pain often radiates in a non-dermatomal distribution. And it's sort of felt that this is much more of a real syndrome where there's something abnormal physically. And some patients with myofascial pain, actually their muscle fibers, their sarcolemma is abnormal, whereas in fibromyalgia, nothing has ever been demonstrated to be abnormal. Okay, myofascial trigger point, I think I've been through that already. What's the treatment of fibromyalgia? Firstly, explaining to your patient what it is and what it isn't, how it's not going to disable her, how her pain is real, it's not in her head, she's not nuts, she's not a hypochondriac, that there's no quick fix. That the things that work are not drugs. Drugs are quite useless. And of the drugs that have been shown to sort of work are the tricyclic antidepressants, though the tricyclics are not used that much these days because of weight gain and of dryness of secretions and the rest of it. But about a third of patients with fibromyalgia respond briefly to antidepressants. How they work, I don't think your boards will ask you, but I've given you a slide. You know the side effects of tricyclics, and perhaps on the boards they may ask you the things like dryness of eyes or mouth, or the quinidine-like prolongation of QT and that kind of stuff. Weight gain is why we don't use it. The other drugs that we try are the muscle relaxants and fibromyalgia, and I think you're going to be expected to know that. You may try them with non-steroidals, but we do quite clearly understand that non-steroidals are fairly useless in any chronic pain situation. These patients sometimes respond well to cognitive behavioral therapy, but the two things that work are stress management and lifestyle modification, to include exercise, water aerobics, the feel-good things, biofeedback, yoga, stretching, those kinds of things, massage therapy. The outcome, unfortunately, in fibromyalgia is rather poor, and most patients, are going to leave your office very frustrated, and I don't think they'll ask you that much on the boards. Complex regional pain syndrome, let's get through this section, and then we'll give you your big break. I think you will be asked about RSD, reflex sympathetic dystrophy, or dystrophic pain. These days we're calling it complex regional pain syndrome. We divide it up into type 1 and 2. In type 1, there usually is a preceding noxious event like trauma, surgery, or spinal or CNS disorders, or even myocardial infarction. There seems to be pain way disproportionate to the initiating event. What you see is edema, vasomotor, and pseudomotor abnormalities, patchy osteoporosis, and the treatment really is very conservative. You try, clonidine patches have been tried, local tender point injections have been tried. Sometimes on the boards what they do is they ask you stuff like, how will you diagnose it? And a bone scan in the past has been suggested as a very useful technique, where you do a 3-phase bone scan, and the third phase of a bone scan, the arterial and then the venous phase. And there's a phase called the pooled venous phase, where in that final phase you get pooling of the venous supply on a bone scan. That's rarely that it's all that useful, but perhaps on the boards that they'll ask